What is it? Okay. Good morning. We will be having a journal club discussion today. Dr. Ramdeep Rai, who is in charge of transplant and hepatobiliary unit at Apollo Glen Hospital, take us through these two scenarios. The first scenario will be presented by Dr. Milind Alokji, where the steroid is being used for preventing post-op nausea and vomiting. So this is a paper which is having a discussion on role of methylprednisolone in preventing skin tissue infection following liver surgery. So Milind, you can start sharing your screen and proceed.
Morning, sir. Sir, are the slides visible?
Yes.
Good morning, sir. I'm Dr. Milind Alokji, second year DNB PGT. Today for Journal Club, the topic I'll be presenting is preoperative single-dose methylprednisolone prevents surgical site infections after major liver resection, a randomized control trial. The primary author of this study was Alexander K. Bresny. Now, this study was published in the journal Annals of Surgery, which has a ranking of 2 among all the surgery journals and an impact factor of 12.96. It comes out around 12 issues per year. Some of the other publications by the primary author include hepatopancreatobiliary surgery workforce in Canada and the adequacy of hepatopancreatobiliary training, how closely do perceptions of fellows and program directors align. Now, coming to the topic, hepatic resections are reliably associated with elements of the acute systemic inflammatory response. Now, we see that in case of major surgeries and hepatic resections, there is an increased acute systemic inflammatory response, and this translates into an increased post-operative morbidity, mortality, and increased length of recovery. Now, this gets specifically pronounced in case of post-operative liver dysfunction, which leads to more increase in the acute systemic inflammatory response. Also, post-operative liver dysfunction will lead to a decrease in the hepatic acute phase proteins and coagulation factors, which is seen to impair the immune defense against bacterial infections, and there is an increased risk of post-operative hemorrhage. Now, the second thing that we have to see about is the acute phase response and the cytokines. Now, very briefly, whenever there is an inflammatory stimulus in the body, it leads to a local cytokine production, and these local cytokines have further lead to a systemic response through mainly IL-6, IL-1, and TNF-alpha. Now, in case of liver, mainly the role of IL-6 has been seen, which leads to expression of hepatic acute phase proteins and release of anti-inflammatory mediators. Now, IL-6 has been known to be a reliable marker of the extent of surgical trauma and an independent predictor of post-operative morbidity. Further, the role of glucocorticoids. Now, glucocorticoids, they modulate both the expression of inflammatory and anti-inflammatory genes. And it has been seen through small RCTs that preoperative administration of glucocorticoids, they have a favorable post-operative change in laboratory markers such as IL-6, and along with there is no increase in the risk of infection. So the aim of this study was to determine the efficacy of a single preoperative dose of methylprednisolone for reducing the incidence of post-operative complication in adult patients undergoing major liver resections. Now, this was a prospective single-center observer and surgeon-blinded parallel group intention to treat RCT. Inclusion criteria was adult patients above the age of 18 years undergoing a major hepatectomy, 3 or more contiguous segments. Now, hemihepatectomies were defined as anatomically true right or left hepatectomies or trisectionectomies, and the remaining hepatectomies were resection of 3 contiguous segments. The indication of surgery was primary or secondary hepatic malignancies or benign liver pathologies. Exclusion criteria included age less than 18 years, those who have already received glucocorticoids, those with additional intraoperative findings that precluded liver resection, and those undergoing minimal invasive surgery. Methylprednisolone was chosen as the glucocorticoid of choice because of the anti-inflammatory action, which is 5 times stronger than cortisol. It has reduced impact on electrolyte imbalance. It has already been used in previous trials, and also pharmacokinetically a single dose was favored. The participants were divided into 1:1 ratio blocks, and they were either to receive IV single dose methylprednisolone or a placebo. Perioperative and intraoperative techniques were same for both the groups, and the clamping, pedicle clamping and closed suction drains were uncommonly utilized. Primary outcomes was the incidence of all post-operative complications within 90 days of operation, and appropriate statistical analysis was used. Now, when we come to the results, we see that the total number of patients who were assessed for eligibility of 195, but finally 151 was the total sample size. Now, among these 151, 77 people were given the methylprednisolone and 74 were given the placebo, and all of them were analyzed, and there was no loss to follow-up due to an electronic medical record system. Mean age was 62.8 years. There were 57% male, and mean BMI was 27.9. Now, here is the comparison, the demographic and clinical characteristic comparison between the steroid and the non-steroid group. And we see that as none of the p-values are significant, both the groups are quite evenly balanced. Next, we come to the operative data. Now, in case of the operative data, 91% of the patients had a midline incision. 84 patients went for a formal hemihepatectomy, and 67 patients for a 3 or more segmentectomies. Mean duration of the surgery was 144 minutes. Estimated blood loss was mean estimated blood loss was 373 ml. And again, in both the steroid and the non-steroid groups, the patients are both the groups are evenly balanced. Now, finally, we come to the post-operative outcome. Now, here we see that when we compare the steroid and the non-steroid group, the total number of complications in the steroid group is significantly less than the total number of complications in the non-steroid group. The p-value is significant. Also, the organ space SSI in the steroid group is significantly less than the group in which the steroid was preoperative steroid was not given. This value is also statistically significant. The overall 90-day operative mortality was 0.66, and the overall complication rate was 41%. Now, the other parameters do not show any statistical difference. The bilirubin and PT-INR both peaked on the second day for both the steroid and the non-steroid groups, but this was also, there was the peak in the bilirubin on day 2 and the peak in the PT-INR on day 2 for the steroid group was significantly less than the non-steroid group. Also, finally, the median length of stay was significantly less for those who received a preoperative steroid as compared to those who did not receive one. Now, the magnitude of the resection in these two groups, they did not affect the outcome, and all cases of organ space surgical site infection were successfully managed with antibiotics and percutaneous drainage. Now, when we come to the discussion, we see that the previous studies that have taken place around the same topic have certain limitations, and these include firstly the small size. The total number of participants in all the combined previous studies was around 370. The same trial has been published. Some of the same trials have been published multiple times. Most of them have very small number of major liver resections, and nearly all of them have used the technique of vascular inflow occlusion, and mostly they have concentrated on hepatocellular carcinoma. Now, as the diagnosis for which the resection was done. Now, this current study is different. First of all, it has gone for major hepatectomies. Why this is important is because in case of major hepatectomies, the duration of the surgery is longer and there is more risk of a post-operative inflammatory response. So therefore, this has to be studied. Secondly, hepatic metastasis, it has studied, focused more on hepatic metastasis because with the current epidemiological pattern has more focuses on the diagnosis of hepatic metastasis than on hepatocellular carcinoma. And thirdly, it has less commonly used vascular inflow occlusion because with the advancement in the electronic, operative devices, vascular inflow occlusion is being less and less used. Now, when we compare the glucocorticoid and the non-glucocorticoid group, we see that the three main things where the difference was the overall complication rate, the rate of organ SSI, and the length of stay. Now, when we compare it with another study that was done by Hayashi et al. In the year 2011, they did not see any significant difference in these three parameters. Although there were certain things that were, they chose to give 3 doses of preoperative methylprednisolone, and their patient population was also a little different. Now, the 3 major studies that the authors have compared are the Hayashi et al., the Srinivas S, and the Richardson AJ et al. Group. This was a randomized control trial, but the other 2 were systemic reviews. Hayashi et al., as I just stated, noted that there was no significant difference between these 2 criteria. Srinivas S et al. Noted that preoperative glucocorticoid decrease the complications such as infection and also the length of stay after major abdominal surgery. Although Richardson et al. They saw that there was a trend towards a reduction in post-operative complication, but no effect was observed with respect to the length of the stay. But all of them noted that preoperative glucocorticoids decrease the concentration of serum IL-6, which is one of the main inflammatory reasons why post-operative complications take place. Now, further, the authors of this study also noted that the lower observed infection could lead to an associated lower length of stay. Now, glucocorticoids have multiple effects such as analgesia, anti-emesis, and anti-inflammatory, and this may have played a significant role in shortening patient recovery. Also, a large majority of patients received epidural analgesia, and this must also have this could have led to a shorter length of stay. Finally, glucocorticoid group in this study showed a non-statistical increase in the rate of DVT, and this they noted requires a further careful evaluation. Now, there are a few limitations of this study, including that the post-op IL-6 and serum candida antigen. IL-6 is a marker of the biological cytokine response, and the serum candida antigen is a response of the bacterial the bacterial infection. They were not noted. Also, that since they were mainly these were hepatic resection and minimal invasive surgery, the response cannot be known. Then others included that now there is introduction of ERAS protocol, and also that data fragility, that is a few more findings on any side could have changed the outcome of the outcomes that the authors received. Finally, in conclusion, the authors have concluded that administration of preoperative single dose methylprednisolone in patients undergoing a subsequent major liver resection lowers the risk of post-operative complications in organ space infection, as well as results in a shorter length of hospital stay and decreased serum bilirubin and PT-INR. Preoperative steroids are safe for use in this setting. Thank you.
Thank you very much. Very nicely made slides.
Thank you, sir.
Very nicely. So what do you understand by surgical site infection?
Surgical site infections are any infection that takes place within 30 days post the operative procedure is termed as surgical site infection. So it can be superficial, deep, or organ space.
So in this case, what is the main difference seen?
So in this case, the main difference that we saw was organ space surgical site infection. So was different in the group that received preoperative glucocorticoids. The incidence of organ space surgical site infection was significantly lower than the group that did not receive preoperative glucocorticoids.
In your patients, how would you diagnose an organ space SSI?
So an organ space SSI, an SSI that surgical site infection within 30 days of the post-operative procedure in the absence of an implant or within 1 year.
How do you diagnose it? How do you detect it?
So if there is a purulent collection in the drain, sir, from the site that we've placed the drain.
Purulent discharge from the drain, or purulent?
Yes, purulent discharge from a drain, sir.
Or there's nothing in the drain.
So if there is a collection in one of the anatomical spaces that has been manipulated during the operation,
which you will detect by what modality?
Sir, ultrasonography, sir.
What is a better modality than an ultrasonography?
So CT scan. CT scan.
If you diagnose, so basically you're diagnosing a collection on a CT or an ultrasound.
Yes, sir.
How would you treat it?
So we would first of all initially go for the conservative management with antibiotic coverage and percutaneous drainage, sir. If drainage can be done, sir, we would go for percutaneous drainage. Go for the culture sensitivity of the discharge and susceptible antibiotics.
You're suggesting that first you would go for medical management, and only if it fails will you drain?
No, sir. First, we'll go for percutaneous drainage. we will start medical management, but we will go for percutaneous drainage, and we will both the things will start along with each other, sir. But percutaneous drainage will be the first line.
Symptomatic collection in the abdomen after a liver resection, you would drain it by radiological guidance. Would you aspirate or would you drain?
Drain, sir.
Drain. Would you add antibiotics or would you not add antibiotics?
Add antibiotics.
Why would you add antibiotics? What is the treatment of an abscess?
Drainage, sir.
Is antibiotics mandatory? So there would be surgeons who would advise, there would be surgeons who would not advise, but the primary treatment is not antibiotics, the primary treatment is drainage of the collection. Why would there be a collection after a liver resection? What would be the reason for a collection?
Bleeding, bile leak.
So basically the manipulation of the organ space and intraoperative bleeding into the space. So
one is bleeding, which leads to hematoma. The hematoma can get infected. And that can lead to a collection. That is one possibility. What is the second possibility?
So bile leak.
Bile leak. So typically what you see is that you drain the pus. The first day the pus comes out, and next day you see that it is bilious, or from the first day itself it is a biloma. If it is a bile leak, what will you do?
Monitor the drain output.
Not sure, sir.
If there is a bile leak coming in the drain, and
so firstly, sir, we'll be monitoring whether the bile leaks are increasing or whether it's decreasing. Sir, it might spontaneously subside also. And
the highest possibility is that it will spontaneously subside because it may be a leak from one of the minor ducts on the cut surface, or even if it's a leak from one of the larger biliary tubes, it may still seal up. If it doesn't, then you can try and evaluate what is the source. Is this a good journal or a bad journal?
Sir, it has its limitations, but sir, they have tried to overcome the previous.
It's a good journal or a bad journal?
It's a good journal, sir.
How do you know it's a good journal?
Sir, they have done a randomized. First of all, they have done a randomized control trial. Sir.
I'm not saying the paper is good. I am asking if the journal. How do you know that the journal is good?
So the impact factor is.
How do you calculate the impact factor?
Sir, it is the number of publications. It is the number of publications from the journal that have been cited in the past 2 years. So I'm not sure about the exact calculation, but that's.
Anyone else who can say what is the impact factor of a journal? Malavika, are you there? Not sure. It is a number of articles which have been cited in the present year in comparison to the number of articles which were published, typically the average of the last 2 years. Makunda, you would like to ask some questions.
Yeah, you said if there is an intraperitoneal abscess, so you said some people not use antibiotics, but if the patient has got associate SARS or systemic sepsis, then antibiotic I think will be must.
Definitely.
It's just a localized collection without any systemic manifestation. Yes, only drainage would be the appropriate. But I think if you say this paper, this is the liver, but this may be true of any major surgery where you have a inflammatory response. So can you percolate this into any other major surgery so that, because all surgery has some incidence of SSI. So do you think
the papers previously published regarding with respect to this study have majorly focused on major abdominal surgeries, including esophagectomies, ventral hernia repair, and sir, this is one of the, and they have also included liver resection, such as sir one systemic study done by Srinivas, So they have focused on all the combined on the major other operative procedures, and so this study has just focused on the liver resection, sir. So more like other studies have mainly focused on all major intra-abdominal surgeries en masse, like on the whole, sir.
I think there's been a paper on cardiac surgery where they've not been able to find any difference in infection rates with steroids.
A lot of anesthetists uses dexamethasone for preventing post-op nausea and vomiting. So how is methylprednisolone scoring more than glucose, hydrocortisone or dexamethasone?
I think you had one slide which said that because it is a more potent dosage.
Yes, so these were the reasons why methylprednisolone was chosen. So the anti-inflammatory action is 5 times stronger than cortisol. It has a lesser impact on electrolyte imbalance, and sir, pharmacokinetically, a single dose, preoperative dose, is effective to cover the whole perioperative period, because the T-half is the biological action lasts 36 hours.
You said the dose is 500 milligram for methylprednisolone?
Yes. Yes.
Yes, sir.
It's a very high dose.
Very high dose. Yes.
This is what we used in transplant. So it's a scary dose actually.
Okay. Any other question from the participants? Anything in the chat box? No.
No, sir.
So Ramdev, is your routine practice to use methylprednisolone for all hepatectomies?
Absolutely not.
Okay.
And I think infections are not really a major concern in liver resection as such. In abdominal surgery, in many cases.
It's more of a clean surgery.
Yeah, so it's not that much of a problem for us to start steroids straight away. Should we move on to the next presentation?
Yeah, we can move on to the next presentation. Next presenter is Dr. Malavika Rao. So we already have a ERAS protocol. So this is another paper where the paper is assessing criteria for safe early discharge after laparoscopic colorectal surgery. So I think this will be in the line of ERAS, but let us see how this paper takes us through. Dr. Malavika Rao is a second-year resident at Apollo Clinical Hospital, Kolkata. Malavika, you can share your screen.
Sir, she is having some problem with the connection. I'll just share her presentation.
Okay, fine. Let's see.
Malavika, can we hear you? Can you hear us? Malavika, are you audible? Can we hear you?
Is added, but
What is? Have you talked to her?
yes, sir. She. I'll just contact her, sir, once. She's added to the chat, but she's not able to respond.
She's online. I can find her online.
क्या हुआ?
इतना आलूटा चले ना छोटा आलूटा.
We're waiting. She's connecting. This is weird. How many days are we doing the classes, sir?
1 year almost. I joined 8th of February last year.
Okay. And how many classes are we doing here every week?
3 classes, Tuesday, Thursday, Saturday.
3 classes.
3.
It's an achievement being able to do that.
Yes, I am continuing with my, touch with the academics. That's it. And all I have about 26 teachers who are taking part by rotation.
Wow.
And these are all streamed in Facebook and YouTube, and a lot of viewers afterwards.
Later also.
Okay, before Malavika joins, Milind, can you tell us what are the criteria for discharge by patient from hospital? When you do a major surgery, colorectal surgery, there are 3 important criteria for discharge of patient from the hospital. Can you tell us?
Sir, the patient should be, sir, the vitals of the patient should be stable, sir. Hemodynamically, patient should be stable.
3. So the 3 criteria should be as per ERAS protocol. One is patient should be ambulant.
Ambulant, yes, sir.
Number 2, patient should be pain-free. And patient should be taking oral diet. These are the 3 important points for discharge. So, you see, vital has to be stable. There is no doubt about that. So, apart from this, if the patient is ambulant, that patient can take care of himself. Number 2, patient is taking oral diet. She is not an IV, and pain-free. These are 3 important criteria for discharge. So, for any ERAS protocol, these are the points taken. And now this is a paper where they assessing the criteria. So I think they might have taken to some other considerations. So Malavika, can you hear us?
He is not there.
Oh, then can
I'll just try to get in touch with her, sir.
I called her just now. She's trying to get. I called her just now.
Yes, sir.
Should we have some discussion on liver resections there?
yes, why not? Please. Yes.
Dr. Milind, are you up for it?
Yes, sir, I can give. I'll try, sir.
So give us some idea about the types of liver resections.
So from what I've read for the paper, sir, there can be hemihepatectomy, sir, where anatomically the true right or the true left of the liver is resected. So if we go for right hemihepatectomy, so that would be segments 5, 6, 7, 8, and in case of left, it would be 2, 3, and 4. So then the other thing was trisectionectomy. So
what happens to 1? What happens to segment 1?
Caudate lobe.
Caudate lobe, sir.
Caudate lobe belongs to which side? Right side of the liver or left side of the liver? You said 5, 6, 7, 8 is right lobe.
Yes, sir. Yes, sir.
2, 3, 4 is left lobe. You're
Yes,
correct.
sir.
So what is the segment 1 belongs to which lobe? Right or left?
So anatomically it belongs to the left, but I am not sure when with respect to surgical resection.
So if you to visualize the caudate lobe, where is it located? The caudate lobe is the synonym for segment 1.
Yes, sir.
Where is this lobe located?
Inferiorly, sir, like on the inferior side, sir, like behind.
No, it is the posterior most
Posterior,
and central most part. So if you look at the IVC, which is behind the liver, the part of the liver that is hugging the IVC or hooding the IVC,
yes,
that is the caudate lobe. Obviously, you can see it from below because you cannot see it from the center. But if you were to cut it, you would see it all along. So that is the caudate lobe, which belongs to neither the right nor the left. So when you are doing a left-sided liver resection, you have 2 options. You can do a left lobe liver resection with caudate, or you can do a left lobe liver resection without a caudate.
Okay, sir. Yes, sir.
And right, as you said. Now, in which condition would you do a left hepatectomy with caudate and left hepatectomy without caudate? Any idea? No. So what are the common indications for doing a liver resection? Common indications.
Hepatocellular carcinoma, hepatic mets.
Hepatic mets from
Colorectal carcinoma.
Typically colorectal. There can be others also, but typically colorectal
carcinoma
is a possibility. That's 2. What else?
Benign liver diseases.
Okay, one is benign liver tumors or benign conditions. Another is malignant. In malignant, you have said HCC, you have said colorectal mets. Any other malignancy of the liver for which you may do a liver resection?
So
you said hepatocellular carcinoma.
Yes, sir.
Hepatocellular carcinoma arises from which cells?
The parenchymal cells, liver parenchymal cells.
Hepatocytes.
Hepatocytes, yes, sir.
Besides hepatocytes, what are the other cells that we see commonly in the liver?
Kupffer cells are there, sir.
Okay, what else?
Biliary radicals.
Yes, sir.
So bile ducts.
Yes, sir.
So from the bile ducts also you may have malignancies. What are they called?
So cholangiocarcinomas.
Cholangiocarcinomas may be of 2 main types.
Distal and proximal.
Yeah.
So distal and proximal.
No. First, you have to see one is from the inside. Intrahepatic cholangiocarcinoma.
Intrahepatic and extra.
Others are extrahepatic. In extrahepatic, you may find hilar, you may find distal, proximal, whatever. So for intrahepatic cholangiocarcinoma, you may be doing a liver resection.
Yes, sir.
For hilar cholangiocarcinoma, will you do a liver resection?
No, sir. For hilar.
If it's high up in the bile duct, theoretically, you can only take out the bile duct. But if it's so high, the hilar,
segment of liver.
To get a negative margin, you have to go into the liver.
Go into the liver, yes, sir.
1 plus to divide to get a hilar cholangiocarcinoma, most often one or the other vessels will be involved. So if you have to divide the vessel, which is supplying the left side of the liver, then you have to take out. So for hilar cholangiocarcinoma, invariably you have to do a liver resection. For a lower bile duct, mid CBD or lower CBD, you may not need to divide it. So what are the indications once again for liver resection? HCC.
HCC benign or malignant.
HCC, intrahepatic cholangiocarcinoma.
Hilar cholangiocarcinoma and metastasis colorectal.
And some rare tumors, which you can leave for below. And on the other hand, you can have benign conditions. Benign. Can you give a benign condition need for a liver resection?
So hepatoblastoma, so that would be a benign tumor. So
forget tumors. What else? Non-tumor conditions.
I just did this.
अभी टाइम है कम से कम.
So non-alcoholic fatty liver disease.
Never.
I'm not sure, sir. I'm not sure.
Hydatid cyst, recurrent hydatid cyst, complicated hydatid cyst, you may need to do a liver resection. Hemangiomas, you may need to do a liver resection. Okay. So whenever you want us to stop, please let us know.
Malavika, I think, could not join.
I think you could not join.
Sir, I'll just...
Milind, you have the presentation, na?
Sir, the presentation is on, sir. I'll just ask her once again if she'll be able to.
She's not able. You just read. You can have some discussion on the presentation.
Okay, sir. Sir, I'm not able to get through to her.
Okay, just Milind, to start presenting. We have discussion at the end. Malavika can join.
Okay, sir.
Just present the slides.
So the journal club is on assessing criteria for a safe early discharge after laparoscopic colorectal surgery. Now this journal was published in the Journal of the American Medical Association, Surgery, January 2022. The author is Clement Travenier et al. This was a prospective non-intervention study cohort. The location, this was done in colorectal surgery, Lyon-sur the University Hospital at France. Sample size was 287 adults and study time was February 2012 to July 2017. The inclusion criteria was all patients undergoing laparoscopic colorectal surgery with ERP, and the exclusion criteria was conversion to open procedure, any other major procedure performed simultaneously, creation of stroma during the same procedure. Now, the primary outcomes that were studies was the diagnostic performance of the 5 criteria in ruling out anastomotic leaks. The secondary outcome was rate of successful and complicated and uncomplicated discharge, rate of all post-operative complications, including AL and death in the group that fulfilled all the 5 criteria versus now the 5 criteria are as follows: CRP level less than 150 milligram per DL on post-op day 1 and 3, or day 2 for patient discharged on day 2, being afebrile or the whole length of hospital stay, being afebrile over the whole length of the hospital stay less than 38 degrees centigrade, tolerating solid diet, return of bowel function, and adequate pain control, that is less than 5/10 on visual analog scale. Now, the perioperative protocol, preoperatively carbohydrate loading, and there was no was done, and there was no mechanical bowel preparation. Intraoperatively, there was no routine urinary catheter, intra-abdominal drains were placed. Maintenance fluid only was given, and opioid-sparing analgesia was given. Now, post-operatively, liquid diet was started on post-op day 0, and ambulatory patient was made ambulatory on post-op day 0 with daily physical exercise. There was opioid-sparing analgesia, and post-operative visits on day 15 and day 30 was done. Now, the results, the mortality, there was no mortality in these patients. The number of patients who fulfilled the criteria was 128, and the number of patients who did not fulfill the criteria, including the missing data, was 125. Anastomotic leak was seen in 15. Of these, 2 fulfilled the criteria and 13 did not. The negative predictive value to rule out anastomotic leak with CRP alone, it was 96.9%. With for 4 clinical criteria, it was 98.4, and for all the 5 combined, it was 98.4. The false negative reports of 40% with CRP alone, 20% for other 4 clinical criteria, and 13.3% for all the 5 criteria. Now, readmission rate, 20 of the 287, that is 7.9%, including 2 who fulfilled the criteria and developed anastomotic leak. 9 out of 139 patients, that is 6.5%, were discharged in POD 3 versus 11 of 148 who were discharged after POD. Of the patients who fulfilled all the 5 criteria but developed anastomotic leak, they were receiving steroids for Crohn's disease, and they were readmitted with anastomotic leak, and there was tachycardia after second day but discharged and readmitted with perioperative. Now, the limitations of this study were that the indications for surgery included malignant and benign conditions together. There was loss of data for around 11.8%, and the surgical technique and surgical experience has not been factored in. This is the review of literature.
Yeah, I think.
अच्छा ठीक है, तो 20 वाला ये ताजा 20 वाला है.
I think it's a nice paper, although there are certain things I did not understand, like why they chose these criteria. What are the basis for choosing this criteria? That has not been specified, I think. They just chose certain criteria and then went ahead with it. That is my understanding.
The point is, actually, in colorectal surgery, the most important concern is anastomotic leak.
Yeah.
So if you can have a discharged patient and patient does not have anastomotic leak, most of the patient will not require readmission.
Yeah.
The most dreaded complication is anastomotic leak, and that is a concern. And if you see there is a leak rate of about 9 or 11%, I think that is 9 million. What is the leak rate they shown after discharge? Come to the
That
slide.
was, I think, the readmission rate probably.
No, the leak rate is also. Milind, come to the slide, which shows number of leaks requiring readmission.
So I think Malavika has joined. So
Hello, sir. Am I audible?
Yes, you are audible.
Yeah,
Yes, sir.
Malavika, welcome. We have been waiting for you for a very long time. And you should have joined much earlier. This is not okay.
This happens.
But so we have asked Milind to go through the slides, and he's already read out the slides.
Okay,
So
sir.
are you ready to answer some questions now?
Yes, sir. Yes, sir.
What is the incidence of leak rate in this patient? Out of, I think 287, they have.
Out of 287, sir, only 15 patients had an anastomotic leak, of which 2 were in the group that fulfilled all the 5 criteria for safe discharge that they were considering, and 13 of them were in the group that did not fulfill the criteria.
But still they are discharged.
They were discharged after post-operative day 3. The consideration here is only on post-operative day 2 or 3. If they are fulfilling the criteria, they would be discharged early. But if they were not fulfilling the criteria, or in certain cases, a large number of 44 patients did not want to be discharged on post-operative day 3, they were kept in the hospital for longer.
And another thing I can find in the paper is they have excluded all the patient who has got an associated stoma.
Yes, sir.
So all these patients does not have a stoma.
All these patients do not have a stoma. Yes, sir.
So is there a subgroup analysis? These leak patients are more of a right colonic resection or left-sided colonic resection? Because you see, they have no bowel preparation. Last week I listened to one gentleman talking from US. He said he routinely does bowel preparation, because there is some controversy regarding around this. Because in Indian population, if you find our patient population who has got very loaded colon, we still think that a bowel preparation is part of good colorectal surgery outcome. And
yes, sir.
A lot of Western people now also saying that they do bowel preparations. Although in ERA's protocol they are saying no mechanical bowel preparation. Is there a subgroup analysis saying how many of left colonic resections are having leaks?
So there was no specification on what kind of surgery was done for the patients who were this one mentioned, but there was a large number of surgery, large number of type of surgeries that were done, including subtotal colectomies, hemicolectomies, all different depending on the indication of the procedure. It's not limited to one certain type of procedure.
Because you see,
they have a significant number of left resections as well. Significant number of left as well.
Because a lot of things come up for anastomotic leak, and the patient whether they have received any pre-op therapy or not. Okay, because these leaks are not only technical part. The leaks has got some patient-related factors also.
Yes, sir. In terms of malignancy, immunosuppression, malnutrition, etc., which was not mentioned specifically. They have not charted these things. They have only mentioned age, sex, and BMI of the patient. And the limitations of this study include the fact that they have grouped both benign and malignant conditions together. So they have not distributed the patient. They have not included the patient factors in the incidence of anastomotic leak.
Actually, we have not been able to practice this ERAS protocol in our patient population, particularly in government hospitals, where we have very little post-discharge care. Because you see, they have got a very organized care. Even at home, they have follow-ups. They have a dedicated system to take the patient back. In our patient population, discharge a patient has leak at home, patient might die at home. That is a problem with our system of treating. Dr. Ramdeep Rai, do you practice ERAS protocol in your center that you discharge the patient?
So we always try to speed up things, but I think even in colorectal surgery, I don't think we are comfortable about discharging till the patient has passed stools, at least.
because nobody wants to go home at second and third day, and then question of litigation.
Yes.
Because you see, even
Which is a
out of
contrast,
27,
which is a contrast from, which I think is a contrast from all other surgery, and including bariatric surgery. In bariatric surgery, I think most centers, they discharge patients and then only after discharge they pick up the leaks.
Yeah.
But in colorectal surgery, I don't think we are unable to do, because yes, the litigation is here and the cost difference, may not benefit that much as compared to the implications of here.
and our follow-up at home, that means a telephonic calls or whatever, that is also not organized in our setups.
So I think most colorectal surgery would still get discharged around 4-5 days, not on 2 or 3 days.
Yeah.
Between 4-5 and sometimes even 6-7 days probably.
So, so how reliable will be these factors? I said because there are few factors we already was there in ERA's protocol. That means patient should be having normal diet, patient should be pain-free, and the patient should be ambulant. And then now they added a few more criteria for the discharge. So what do you think, Malavika? What should be the status of this criteria? Can you safely discharge patient based on this?
So from this, if the negative predictive value of anastomotic leak is much higher than the positive predictive value, you cannot predict an anastomotic leak from just a raised CRP level or any of the factors and that were mentioned. But altogether, the negative predictive value is very high for anastomotic leaks. But if you, part of the trial that they have done is if you exclude any of the information, any of the factors, then the negative predictive value decreases accordingly. So as in together, even though another thing is the number of complications in the rates of the group that fulfilled the criteria, did not fulfill the criteria, were not very different. So it could be possibly an criteria for assessing safe discharge. From the review of literature that I have done, there is no other criteria for assess. There is no other completely formulated criteria for assessing safe early discharge, and this is the first one that I have come across. The others use CRP values isolated or CRP with procalcitonin to assess the anastomotic leak, the possibility of anastomotic.
So while we may not use this paper for discharging patients, how can this paper use us in clinical practice?
So in clinical practice, for at least for benign conditions or patients who are not supposed to be receiving follow-up radiation or chemotherapy, which can predispose to more anastomotic leaks post-operatively, we can use this for benign conditions possibly, or at least explore the possibility.
My point is, as Dr. Makunlal Shah also said, that we may not be in a position to discharge patients on day 2 or day 3. But still, we can use this paper because it helps us in predicting leaks. So what it means is, even if you can pick up a leak 1 day earlier, it can reduce the morbidity. So when you're at the bedside of the patient, if you have a paper like this, then probably you can do investigations. For example, you might decide to do a CT scan. That you may decide to do earlier. So your suspicion raises, rather than wait for the patient to pass stool and then say that there is no leak, you can have some leaks. So besides this paper, besides the CRP, are there any other scoring systems which try to predict anastomotic leaks?
There is a scoring system called Dutch leakage.
Can you tell us more about
it? No, sir, I don't know much.
Yes, the idea of the paper is that when something is mentioned, you have to, go through that, because that's a very interesting scoring system, and that includes those factors which we already think of in our clinical practice. Like the white cell count rate, like the heart rate, the pulse rate, whether there is agitation, whether there is clinical deterioration. It also includes CRP. Then
basically, the first criteria to say SARS. Any patient having a SARS in the post-op period is a suspicious patient. You take into
Sorry,
account the
sir.
criteria of SARS.
Sorry, sir.
SARS, Systemic Infinite Response Syndrome. Here's some criteria for SIRS.
Oh, yes, sir. SIRS is if there is a temperature of more than.
Yeah, that's one thing. We have some criteria. So
Yes,
any
sir.
patient having SIRS in the post-op period, that is one important marker that the patient is having some problems.
Okay.
And in fact, CRP is a non-specific criteria.
Yes.
Any others SSI can cause rise of CRP. Patient having a pneumonia or any other chest complication may have a rise of CRP.
Yes, sir.
And more so when you are not putting drain. Once you're putting a drain, you may have say frequent discharge in the drain. Patient has got some abdominal signs you can make out. But once you're not putting drain, one should be more vigilant and have some specific criteria to diagnose this. Because the diagnosing anastomotic leak early is important to prevent morbidity and mortality. Some patient may have mortality if you are not picking up and addressing this leakage.
Yes, sir. Here the routine drain was not routinely placed, but occasionally, if the surgeon was suspecting chances of bleeding, then there was a drain placed, which is removed.
The whole series they put drain. In this series, drains are not put.
No, so they were not routinely placed, but in the discussion it was mentioned that it was placed for patients who, when there was suspicion of bleeding.
Acha, okay.
Yes.
Okay, Dr. Rai, any other comment?
Then thank you.
Thank you. Thank you, Milind. Thank you, Malavika.
Thank you, sir.
Thank you.
Thank you very
Thank
much.
you, sir.
Sorry.
Ramdeep, I'll ring you today.
Thank you, sir.